This video is for you if you're someone that suffers from vertigo or dizziness and you're not really sure about what's going on, you're wondering if there might be a different cause. I'm going to talk about vestibular migraine and describe what it is, and you'll hear about how common it is too, and unfortunately how it's still underdiagnosed, and there are some reasons why that's the case. But let's dive in. Vestibular migraine is a really common cause of dizziness, but it's underdiagnosed and it's undermanaged and misunderstood. And partly that's because when people think of migraine, when most people think of migraine, they think of the really nasty head pain that can come with migraine. With vestibular migraine, you don't necessarily need to have head pain. It's not the main feature of this kind of migraine, and I'll explain as we go along. Vestibular migraine is a migraine that involves episodes of dizziness, vertigo, or balance issues. And because it's only been diagnosed in the last 10 years or so, there's still a lot of misunderstanding about it. And surprisingly, it doesn't get picked up or identified as the problem as often as it probably should. People can talk about sensitivity to head motion, so just moving the head around. They can talk about sensitivity to what the environment is doing around them too, or it can be a sensitivity that gives them a sense of imbalance or tilt. And those feelings of imbalance or tilt can be quite sudden in their onset, which makes them a little bit different to other forms of dizziness. The sensation can be quite spontaneous without necessarily involving head movement to precede it. Symptoms can last from minutes to hours and even days, and you can imagine if you've got dizziness like that for days, even hours, it can really get in the way of achieving what you need to get done in a day or in a week for that matter. Vestibular migraine is surprisingly common. It's the most common cause of spontaneous, non-positional, episodic vertigo. So let me go through that again. Spontaneous meaning it can just happen out of the blue. Non-positional meaning it doesn't necessarily relate to changes in head position or movement. And episodic meaning it's something that comes and goes. It comes in episodes. The estimate is that it affects between 1% and 3% of the general population, which is quite a bit considering that the other common cause of dizziness is benign positional paroxysmal vertigo, which is around about the same prevalence, 1% to 3% of the population. And it's estimated that up to 30% of people that present to a dedicated headache or migraine clinic can have vestibular migraine, which is incredibly high. To give you a bit of an idea of the way that it can be underdiagnosed, there was a study that looked at people that presented with dizziness symptoms, and in that study, only 1 in 10 of people that fit the criteria were actually diagnosed as having vestibular migraine. So that's quite a big chunk of patients that were not diagnosed correctly, it seems. Defining vestibular migraine relies completely on clinical symptoms, on the history-taking side of things. There's no lab test, there's no blood test, there's no imaging or any other kind of investigation that will distinguish it from a different kind of dizziness. So it all comes down to the description of how it behaves. The International Classification of Headache Disorders, 3rd edition, ICHD3, has certain criteria that need to be fulfilled for a dizziness issue to be diagnosed as vestibular migraine. And these criteria are at least 5 episodes, a past or a present history of migraines, vestibular symptoms, whether that's dizziness or vertigo, lasting between 5 minutes and 72 hours, and a migraine, headache, or other migraine-associated symptoms in half of the episodes at least. Migraine-associated symptoms might be aura of visual disturbance, for example. So what are the symptoms of vestibular migraine? Well, there's really 2 components. There's the vestibular symptoms, which are more the dizziness or the vertigo, and there are the more migrainous components of it, like a typical migraine episode, or the associated symptoms of a migraine, which might be, as I said before, it could be visual disturbance, it could be something else, but something that's typical of someone's aura. Symptoms can be between 5 minutes and 72 hours or 3 days, which is quite a big range, but then there are also descriptions of symptoms that last outside of those ranges as well that can go a lot longer than 3 days too, up to a week. And the symptoms can mimic other vertigo or dizziness disorders like benign positional paroxysmal vertigo, BPPV, or the auditory symptoms of Meniere's disease as well. Some of the common symptoms during an episode are nausea and vomiting, phonophobia, which is sensitivity to sound, photophobia, which is sensitivity to light, and visual aura, which can include either a loss of visual field, like losing half of your eyesight, or disturbance within the visual field. It's really important to note that the migraine symptoms and the vestibular symptoms don't have to happen at the same time for it to be diagnosed as vestibular migraine. And I feel like this is one of the things that can muddy the waters a bit when there's an assumption that for it to be vestibular migraine, it has to be dizziness within the migraine episode, and that's not the case. Vestibular migraine can be episodes of dizziness, vertigo in someone that has a history of migraine or someone that has had a recent attack of migraine. So they don't have to overlap. And it's important to remember too that the migraine symptoms don't necessarily have to be head pain. So once again, it's another thing that probably muddies the waters a little bit in a lot of people's minds when they think vestibular migraine, it's dizziness in the presence of migrainous head pain. But in fact, it can be a dizziness or vertigo at quite a separate time to migrainous symptoms. And the migrainous symptoms don't have to include the head pain. It can be visual disturbance of an aura. It could be sensory disturbance of an aura. It could be any number of things that can come with someone's migraine episode that don't necessarily involve the head pain. There are no confirmed causes for vestibular migraine. However, there are a lot of theories, and the theories involve the connectedness between the areas of the brain that are involved in balance and vestibular function and the areas of the brain that are involved in migraine. And there is a lot of interconnectedness between the two. The vestibular system hyperexcitability that's found in vestibular migraine patients may relate to this, or it may relate to the vestibular organs, or more likely a bit of both, a bit from column A and a bit from column B. And the other important connection to this whole region of the brainstem that's involved in bringing all this information together, of course, is the upper neck, which has got a really critical function in terms of being able to integrate what you're doing with your head and what you're doing with your neck position. For example, if you tilt your body forward, there's no way for your vestibular system to be able to differentiate between whether it's just your head going forwards at the neck or whether it's your whole body going forward. So the neck is a really critical part of that balance system to help to provide more data, more accuracy to describe what's actually happening with your body at the time. So that's just a really simple example of it. And if you think about from a survival point of view, it's really critical for you to automatically, outside of your consciousness, to know that your head is turned in the same direction as your eyes, putting all that information together so you can respond quickly and accurately to what's going on in the environment around you. In vestibular migraine patients, there's a change to the processing of information. There's a change to the processing of the way that spatial and visual information is being integrated. And if what you're seeing and what you're feeling through vestibular apparatus or through your body, joint receptors, muscle length receptors, all the different receptors that can be providing your brain information, there's a mismatch between them for whatever reason, then that sensation of dizziness or vertigo is the result of that. There isn't enough evidence from randomized controlled trials to show that any medications are useful for prophylaxis, as in prevention, in vestibular migraine. And there are only a few randomized controlled trials about treatment for acute attacks of vestibular migraine. The common advice is that vestibular migraine can be managed with a combination of medication, lifestyle changes, dietary changes, and vestibular physiotherapy. Some of the dietary changes as suggested are removing red wine and cheese and chocolate and MSG from the diet, which seems to me personally like a fairly dramatic response unless it's a proven trigger for a vestibular migraine episode. So it's trial and error. You try it, I suppose, and see what happens. And there's certainly evidence to show that vestibular rehabilitation with a physio is effective in helping people with managing vestibular migraine. Here at the clinic, the way that we approach vestibular migraine, and this is informed by 10 plus years of experience of treating headache and migraine problems, our first line of attack in managing people with vestibular migraine is in recognizing the role of the upper neck, the interconnectedness with the top part of the neck in particular, and the brainstem, and the connection between the areas that are involved in headache, the trigeminocervical nucleus and its excitability, which is found in headache and migraine sufferers, but also the integration of that information from the neck with other areas of the brainstem that are involved in balance, regulation of posture, and orientation of the head. And we've certainly found that at the very least, screening the upper neck first is useful. And it's interesting when you read through the vestibular migraine literature, there's really no reference to the role of the upper neck. It's all thinking about it from a vestibular organ point of view or from a central brainstem point of view. But this section of your body has got a really, really potent input to your maintenance of balance. And it makes perfect sense to me that there could be an important contribution from that part of the neck. So we start there. We start by screening the neck because there's some fairly routine things that you might expect to find if the upper neck might be involved. And then treating that and starting with a small number of sessions for proof of concept, if you like. It's important to say, if someone's coming in and they have symptoms, a description of the episode that's very suggestive of a different cause of dizziness, we won't start there. But if someone happens to present and what they're describing is something that's quite consistent with vestibular migraine, and it's not suggestive of other forms of vertigo, like in particular BPPV, then this is where we tend to start. We'll check the upper cervical spine, screen it for the things that we might expect to see if there's a neck component, and treat that and look for a change fairly rapidly. Certainly within 5 sessions, often it's quicker. Often there'll be a noticeable change after the first session. And if there is, then we can be pretty certain that that's an important component to the problem. At the same time, we'll always address the importance of sleep, the importance of exercise, the importance of management of stress, which these 3 things can easily be triggers for vestibular migraine. In particular, sleep, poor sleep quality seems to be an important factor as a trigger. And stress does too. Stress seems to be a fairly regular trigger for vestibular migraine. In other people, there's a really clear trigger where an episode is related to head movement. So in summary, vestibular migraine is a very common, relatively new problem to be described, misunderstood, underdiagnosed. The criteria are according to the ICHD-3, as I've described earlier, but as you can tell, it's all based on symptomology, on what you report. There's no objective test that determines whether something's vestibular migraine or not. And we've certainly found that screening the upper cervical spine, using the Watson headache approach to do that, and looking for those signs that might suggest involvement of the upper cervical spine has been very effective. And we usually see a rapid change in the condition if it is a big contributor to the vestibular migraine problem. So if you have dizziness, if you have vertigo, and it's an ongoing thing, and it's a little bit vague and it doesn't fit into a particular category like BPPV, and you're not satisfied with how things are going, then it would be worth ringing us, coming into the clinic, giving us a call and just having a chat on the phone and see whether we're likely to be able to help out or not. And we can talk through our procedure for treating vestibular migraine and see what we can do to help out. I hope that video is helpful. I hope that explains a few aspects of this quite common problem and gives you a little bit more direction and perhaps a little bit of hope if you're someone that suffers from dizziness and you don't feel like you've got any options left and you're just reliant on medication. Cheers.